Good afternoon. My name is Filippo Pinto Ivairo, and I'm an associate consultant in the Center for Individualized Medicine and Department of Clinical Genomics. I would like to welcome you to the Center for Individualized Medicine Grand Rounds. The SIN Grand Rounds lecture series is designed to highlight the latest in scientific discovery and innovation and demonstrate how individualized medicine is being translated into practice to meet current and future patient needs. In celebration of the Rare Disease Day this week, it's my pleasure to introduce today's presenter, Dr. Durhan Wang Rieger. She is the president and CEO of the Canadian Organization for Rare Disorders, immediate past chair of Rare Disease International, president of Asia Pacific Alliance of Rare Disease Organizations, treasurer of UN NGO for Rare Diseases, chair of Patient Advocates Constituency Committee of the International Rare Disease Research Consortium, member of Lancet Commission on Rare Disease, and member of the editorial boards of the Patient-Centered Outcomes Research and Rare Diseases and Orphan Drugs Journal, and Global Commission to End the Diagnostic Odyssey for Rare Diseases. In Canada, she is also president and CEO of the Institute for Optimizing Health Outcomes and chair of the Consumer Advocate Network and Canadian Heart Patient Alliance. She is also co-chair of Canada's Rare Disease Drug Strategy Implementation Advisory Group, member of Canada's Rare Disease Network Steering Committee, and Canada's Newborn Screening Advisory Group. Dr. Wang Rieger has a PhD in psychology from McGill University and was professor at the University of Windsor in Canada. And she's a certified health coach, lecturer, and author of 3 books and many, many articles. Today's presentation is called Reimagining Rare, Reconciling Opportunities of the Most Advanced Technologies and the Challenges of the Most Underserved and Undiagnosed Persons. With today's presentation, we will be exploring the importance of global collaboration in the rare disease community, from family-run support networks to virtual specialty clinics and multi-country clinical trials. Despite efforts by the UN and WHO through rare disease declarations and resolutions, achieving equity in diagnosis and treatment remains a challenge. Advances in genomics and AI have the potential to improve access, but they also risk widening disparities. This discussion will highlight why equity matters across all income levels and showcase recommendations and successful practices from around the world. Throughout today's talk, for those online, please use the Q&A in Zoom to submit your questions. We have planned time for Q&A at the end of the session, and for those in person, we will pass a microphone around the room. For those who have not yet claimed CME, the code is RARE, R-A-R-E, all caps. And with that, please welcome Dr. Durhan Wang Rieger.
So thank you so very much, Dr. Pinto Varro, and it's great to see you virtually. I wish, in fact, I were there with you, but this is probably the best option. Thank you very much for the opportunity to speak with you on right in advance of Rare Disease Day, and really hoping that we're able to use this as a bit of a kickoff to what I think is certainly one of the most important issues coming up. Well, two of them combined, actually. One is, of course, the increasing integration of rare diseases and precision medicines, targeted diagnostics, and also the challenges, I think, as Dr. Pinto indicated, we're getting more and more opportunities with the technology for rare and precision, but the challenges I think we all face are with regard to equity. So I'm going to provide a bit of an introduction in rare. I think a lot of it you probably will know, but just to kind of set us all on the same page, talk a little bit about what we understand in terms of some of the directions for rare and precision. But also, I'm going to end with some discussions around one of the areas I spend a lot of time in, and that is in the Asia Pacific and also, especially in Southeast Asia. In fact, I was just saying right before I just came back from Singapore last week, and it was about 29 to 36 degrees there, so a little bit different than what I walked home into. So with that, I'm going to share my screen and hopefully I will be able to get started here. Hopefully that works for everybody. Okay, I called it Reimagining Rare because I think we are at a very interesting time. I know we always talk about being at inflection points, so that we're looking at sort of paradigm shifts, but I think increasingly we're looking at great opportunities, as I said, but also tremendous challenges. And I'm not real sure, how do we bridge the gap, if at all? So I think this is what we live in the rare disease world believe, and that is there is something very unique about rare that is, of course, common across all of these rare diseases, and that is the fact that because they are rare, there's oftentimes lack of knowledge and lack of information, but also a lack of inclusion, whether it's in society due to culture and stigma, also due to the health policies that may not necessarily be set up to deal with very small patient populations. Certainly a real challenge in terms of the lack of policy, and even where there are good access in many cases, without comprehensive policies and integrated care, we have huge disparities. I think increasingly, though, as we talk about rare, we're talking about global, and it needs to be global in part because of the small numbers. But we're also then talking about, moving from countries with high technology, high income, to where rare diseases certainly are prevalent, but really have very little access because of both economic, other kinds of services, and barriers and challenges. So, really what I feel important and rare is that it really tests us in terms of what we can do in terms of advances with technology, but can we bring along then those that are going to be the least capable of taking part? This is a low slide that I like, and we kind of did it in Rare Disease International. And again, what makes a rare different, and certainly different when we talk about it from precision targeted, diagnoses with more common diseases, and that in many cases for rare diseases, it starts with people not knowing that they've got a rare condition, a rare disease, and oftentimes what we call that long diagnostic odyssey to get to a diagnosis. Oftentimes having many encounters with emergencies, with healthcare professionals, with other kinds of professionals. Oftentimes, I think as the literature has shown us and our experience has shown us, getting anywhere from 1 to 12 misdiagnoses and seeing scores of healthcare professionals before we get to a diagnosis. And oftentimes, even when getting to a diagnosis, then having no real clear pathway to getting good care, support, or to getting to treatments, even when they are available. And this is, of course, I think quite unique to rare diseases. Many other conditions, of course, have these challenges, but for rare, of course, there are so many more barriers and obstacles due to the lack of numbers, due to the lack of awareness, due to the lack of research, due to the lack of dedicated care and support. So as I think you saw, I mean, with the numbers in terms of how many rare diseases are seems to increase. It could be 7 to 10,000 rare diseases, depending on how you want to count what is a rare disease. Certainly, we know that most of them are genetic. Important thing to recognize is now, thanks to, and we'll talk a little bit more about the Orphan Drug Acts, we've got more than 880 orphan drug approvals. When I think, as we said, before the Orphan Drug Act in the US, there was probably only 10 new therapies per in the decade previous to it. Most of them are pediatric. Important thing is this is why we say increasingly common and increasingly rare. We're getting more and more rare diseases, so that's kind of more common. But many of the rare diseases we're now diagnosing having a very small point prevalence. Almost 85% of them are what we would say are fewer than 1 in a million. In many cases, diseases that we call, N of ones, that there may be only one patient, one family that's identified. Though I think as we start to probe deeper and the genomics that we're using become more sophisticated, what we're finding that maybe some of these ultra rare and seemingly isolated cases maybe are not so ultra rare or so isolated. We just aren't looking in the right places. We aren't doing the things that we need to be able to do to identify some of these patients. But really, could be up to 300 million. We say easily 450 million people that are affected by rare diseases worldwide. This is just a little slide I put together just to kind of illustrate, I think, what the landscape is that I think we're dealing with. On the upper left-hand side, we're talking about common diseases, high prevalence, infectious and chronic diseases. And there you see some of the most common with them, hyperlipidemia, for in fact, high blood pressure affecting, more than 40% of people, and things like high cholesterol affecting, 12, 15% of people, and diabetes as well. On the bottom left, of course, are what we're talking about in some of our rare diseases, even the most common rare diseases affecting a still very, very small patient population. So 1 in 4,000, 1 in 5,000. On the upper right, we're talking about many conditions that we're talking about are absolutely complex, multifactorial, multisystemic impact. And again, more common conditions, but the manifestation can be quite different across individuals. And what we're getting now, of course, with many of these complex conditions is the ability to actually be to identify very precise targeted patient populations, at least from a genetic genomic point of view, within what was previously seen as a common condition. And even common conditions in cancers are showing us that way. What looked like when we look at the topography of it, a very unique condition is in fact when we start to look at the underlying causes of it, especially genomically, the same cause can actually be manifest in many different kinds of cancer. So, whether we're defining a disease as a breast cancer may not be as meaningful as what is the underlying genetic mutation that is causing the kinds of tumors that the patient may be experiencing. So, and of course, the treatment protocol for that based on the actual genomics as opposed to the where it's located. So this is just for me sort of an interesting way of thinking about how we're trying to move through what is this next landscape of rare and precision precise diseases. So as we say, common diseases are now becoming increasingly rare mutations. I was actually quite surprised just digging into the research a little bit in terms of how many genomic variations there is. And I actually didn't quite believe it the first time I saw it. 100,000 genome mutations across various types of cancers. Really? 5,000 genetic variations for different types of cardiovascular diseases, cardioarterial deficiencies, familial hypercholesterolemia, cardiomyopathy. And then, of course, for the diseases that we think of, very common, we know that there are many types of them. But when we start to look at the genetics, my daughter-in-law has type 1 diabetes, many, many variations of it. And now we're looking at being able to do things around gene therapy for some of those if we can identify them precisely. And the neurodegenerative, I think, is going to be the biggest area that we're going to be able to make some advances. Now we're beginning to understand how can we treat some of these diseases that we used to think about as one disease. Well, we didn't really think about them as one disease. We knew there were many, many variations of them. We just didn't know how to identify them. So 20 genetic mutations for Alzheimer's, my gosh, what, maybe 200 genes that can influence. My husband has Parkinson's, and we know that there have been no really good treatments, all symptom management. And in part because we always thought, we always looked at Parkinson's as a disease, even though we knew it wasn't. It was mostly a disease by exception. And now beginning to understand what are some of the genetic mutations in there, and then began to really target then some of the therapies around specific mutations. So this is, I think, making, as I say, some of the biggest breakthroughs that we're going to see in terms of medicines, where we've got common conditions that are really not going to become, for all intents and purposes, rare diseases. And this is kind of what the excitement is, I think, for many of us, is the fact that we now can do genome specific diagnostics. These are some of the cancer diagnostics that you're looking at, not just single gene tests, which were the beginnings of when we looked at in terms of breast, or we're looking at in terms of lung cancers, melanomas. But now we've got multi-gene panels that are allowing us to test across different kinds of tumors, and especially now going into the solid tumors, beyond the blood tumors, and then very biomarker specific tests. So this is really helping us to be able to really zero in on the causes of these diseases. And really, again, as I said, the goal is to actually have treatments that are matched to these targeted diagnostics. Very exciting as well. And, what we're doing, obviously, in the rare disease place is increasingly many of these targeted cancer mutations are coming to us as well for help in terms of being able to identify patients, work with the patient groups, do the kinds of submissions that are necessary in terms of raising awareness of them. And the overlap now we're finding between, what are common conditions and rare conditions is huge. I'm doing, so much more, for instance, with regard to kidney diseases, liver diseases, and certainly with regard to some of the blood conditions that are really much more crossing over between common and rare conditions. It's very exciting. And I think for many of us, we're really looking at a future where we're going to be able to precisely diagnose conditions and we're going to be able to precisely treat them. The challenge, of course, is that, how do we actually going to manage them in terms of our healthcare ecosystem beyond just the access to them? But I'm going to take a step back and just talk a little bit about that healthcare ecosystem. I think, as we know, orphan drug legislation certainly starting, though not just starting in the US, was a huge step forward in terms of our being able to provide incentives for developing therapies for what are rare conditions. And, two biggest areas, of course, is in terms of two biggest countries are US and in the, well, Europe is not a country, but the European Union. And as we can see, there have been so many approved treatments that have come out of these orphan drug legislation, orphan drug acts, to the point where we have actually more than 1,000 approved rare disease drugs in the US, but about 880 of them are unique. And then we've got, now the inclusion of other types of innovative technologies which are helping us to accelerate diagnosis and treatment and even going into prevention. So gene-based diagnosis, as we just talked about, newborn screening, that's moving beyond genetics testing to genome sequencing, with some countries actually, or some cities as well, jurisdictions looking at genome sequencing for newborns, so newborn genome sequencing, and the ability to bring in then, precise therapies on that end. The other excitement for many, of course, is the technologies in terms of digital health and wearables. This actually becomes a huge part when we talk about some of these precise therapies, because the ability to monitor the impact in patients is hugely advanced by the ability to have, ongoing patient information being submitted through these digital technologies. Again, my daughter-in-law, who has type 1 diabetes and wears the diabetes monitor, the information that is actually collected and able to be transmitted is unbelievable in terms of really keeping very much up to date in terms of how well, her treatments are working, but also kind of where her overall status is. So we're really entering into some amazing, realms with these technologies. The financing is both a huge opportunity, of course, a huge challenge. I think certainly the technologies, the advances we're seeing, the ability to really precisely treat conditions, precisely diagnose them, really fueling a lot of investment, which makes great sense. Also, as we know, it's really challenging payers, though. Healthcare systems, whether they're wealthy or whether they're really, already underwater in terms of financing, the costs in terms of new technologies are tremendous. Costs in terms of new drugs are tremendous. Costs in terms of new testing is tremendous. This is, this little bit of a, paradox where we've got increasingly more and more effective technologies, an increasing challenge in terms of the ability to pay for them, even in the best of circumstances. What we do know is that at a global level, rare diseases are taking on a tremendous profile. And this is really, I think, part of what we've been doing at Rare Diseases International to really raise and include rare diseases in some of the global policy platforms, universal health coverage, declaration on rare diseases, and now moving towards a WHO global network and a WHO resolution. So working more globally in order to be able to adequately address these diseases that are, really represented across the globe, but in very small numbers in any specific country and even in specific regions. So we know that a great deal more regulation is needs to be coordinated, and that is not only just in terms of the regulations for clinical trials and development, but also regulations in terms of approval, regulations actually moving across in terms of the approvals for reimbursement. So we're seeing, certainly across Europe, more consolidation in terms of the health technology assessment, looking at how well they work, what are the returns and investment for them, and we're also looking at, most importantly, increasingly coordination in terms of data and the ability to collect data, not just for the front end in terms of developing and the research, but as importantly, the collection of what, real world data. How well are these treatments working in real life? What is it we're seeing in the long term from patients? And increasingly focus on the ability to collect that information and to be able to bring it together to actually meaningfully analyze it, and to then be able to put it back into ongoing research, ongoing development, and ongoing more precision in terms of the guidelines for treatment. So this is, of course, I think something that we're all dealing with in the same way as we're having real challenges around, privacy of data and the ability to make sure that we can protect people in terms of their individual data. We're also having hugely more needs for that data to be able to be shared. This leads us into talking about the kinds of data registries and the ability to use these data registries to be sort of fuel, I guess, and sort of information for artificial intelligence, which is, of course, that big game changer in terms of how we're going to be doing the research, how we understand diseases, how we're going to be able to make sense of how well the treatments are working in a real world environment, and be able to help uh, both practitioners but patients themselves be able to access better knowledge in terms of getting much more accurate, not just diagnosis, but more targeted treatments. The other last thing I want to talk about is where the space I live a lot in, and that is, of course, in the patient community. What we're seeing, of course, is patients themselves, who were the drivers even around the orphan drug legislation in the U.S. and in Europe, and huge factor in terms of getting that legislation in place and also bringing together patients from across many diseases. We're now much more organized, globally. So with Rare Disease International, which is celebrating its, I think, 10th anniversary this year, uh, South American, Latin American alliances, which have been coming together, bring together countries in Latin America, and also coordinating some with the Spanish, Portuguese speaking countries in Europe. Our Asia Pacific Alliance of Rare Disease Organizations, which I am now president of, and trying to bring together countries across Southeast Asia, Asia itself, and also Pacific and Australia, New Zealand. And the Africa Rare Disease Alliance, which is still having a lot of challenges in terms of coordination and really working together, but a lot of people working behind the scenes or working individually, in partnerships, trying to forge better collaborations across Africa. The last thing I want to put in this category, I think, as we all know, is that a lot of the research now is actually being driven by patient consortiums. And I can't overemphasize how important this has been, both in terms of coordinating patients, in terms of collecting the data and having them available, in terms of collaborating with researchers in academic institutions, in companies, but also making decisions about where the direction of that research are to go, which projects are going to be advanced, especially in some of these conditions where we see a lot of trials taking place. We're getting, even more opportunities to think about how do we drive it. And then, of course, we have patient groups that are themselves leading the research and funding the research and actually coordinating the research. So a great deal more that's happening in terms of patient consortiums. And again, many of them not just in a country and not just regional, but really having global outreach. So this is one of the things I just want to talk about, and I know that we had, I mentioned it briefly. For me, of course, one of the most exciting areas that we're moving into is the use of AI. And I just wanted to focus on diagnostics for a moment because it is, in fact, so very important when we think about, what we're doing in rare diseases or in precision. Medicines in precisely identified diseases, and that is to be able to get the diagnostics. I kind of one of the reasons I was very excited, and we're involved in a number of projects. Some of the projects I've given you here are some of the ones that I'm personally kind of connected with, is the challenge we have in terms of finding patients. Speaking with some of the companies we have that are bringing in these highly innovative therapies, some of them for very rare and almost ultra rare conditions. My question oftentimes to them is like, how many patients do you think we have that are affected by this condition? And some of this is Canada here. And how many of those patients do you think you have that you have been able to identify to bring into getting access to therapies? And the answer I get, oftentimes is really dismaying. Well, we've got 15% of whom we think are, patients that are out there, maybe up to 40%. And the challenge we have is we can't diagnose them, we can't find them, we can't identify them. In part because many of them have been undiagnosed or misdiagnosed. They're in the healthcare system and they're actually showing up, but they're often showing up in emergency rooms. And this is for children. I hear over and over again from our children's hospital, 90% of my kids that are in my emergency room are kids with undiagnosed rare conditions. I've got kids, and adults as well, that are in critical care beds that are being treated for symptoms, what seem to be ordinary kinds of conditions. Well, I shouldn't say ordinary, but they're conditions. One of the diseases, for instance, that we're working with, we got a therapy for. One of the symptoms is actually kidney stones. The problem is the patients are getting treated for kidney stones and nobody's actually kind of taking the next step to say, geez, maybe there's something else going on. And that, especially if you see a patient with kidney stones coming in, on a regular basis. So the challenge is trying to identify some of these patients for whom we do have treatments and who are not, getting diagnosed or not getting diagnosed early enough and not getting diagnosed until they're quite symptomatic. And even then, sometimes not getting diagnosed at all. So I'm very excited by our partnerships with some of these AI companies that are actually bringing in amazing diagnosis. Cure Health is a group in Canada who's now partnered with Healthwell, and have been doing diagnosis going into the medical records, but also making their screens available to healthcare practitioners, primary care practitioners, and helping to, as I say, they've now helped identify 43,000 high-risk patients across 8 clinical specialties, utilizing 132 disease-specific algorithms. So here's an algorithm. Here are patients who are potentially high risk for certain kinds of diseases, either making them available to physicians or actually going into the medical records themselves. Mendoscan is one of the companies in the UK whom I have kind of come into contact with, and amazing what they've been able to do, especially in a country like the UK where the National Health Services actually has patient data records, and they can actually go into them, identify patient at high risk, be able to go back to clinicians and say, we've identified patients. Are you interested in terms of receiving that information, potentially contacting physicians, allowing them to actually be further tested to see if in fact they may indeed have a condition or be at risk for this condition. So this is, I think, very important work that we're able to do in terms of identifying people sometimes before they become symptomatic or seriously symptomatic, or identifying them to link them to, available preventive therapies. Savantech is a company that is based in Warsaw, in Poland, and right now in Canada, and are using their AI algorithm for 50 rare diseases, going again into specific clinics to identify potential patients. Genotips is actually a Canadian-based company, which I think has been amazing, now has a platform in 60 countries. And what they've been able to do is to integrate, electronic health records to actually go beyond just the genetics and genomics, but actually be able to include phenotype data to actually come up with disease profiles. And again, being able to go into this record, identify patients with these profiles, and flagging potentially patients, and especially high-risk patients for specific rare conditions. Think Rare is a new initiative that I'm really excited about. It's again based in Ottawa with our Children's Hospital Eastern Ontario, which has been a real pioneer under Dr. Kim Boycott for advancing, using genomics to identify patients with unknown, unidentified diseases, highly symptomatic, being able to identify a large number of these patients, at least give them a diagnosis to help understand kind of what is causing the symptoms or what might be a bit of a prediction in terms of what prognosis might be, even if there's no specific treatment and certainly not a cure for them. So we're really excited about this newer initiative that is taking place. And again, being able to hopefully spread it beyond the few clinics that we've got. And I love the face-to-face gene because what they're doing is going back to some very basics to say, look, some of it we don't really need genetics and genomics. We can actually identify a lot of rare disease patients based on phenotype, based on symptoms alone, and certainly facial recognition in terms of potential indications of disease. So all of this, I think, is a huge opening for us to be able to not necessarily, well, yes, in some cases, identify new unidentified diseases and creating new genetic genomic profiles or new phenotypic profiles, but also, as importantly, finding those patients who are living with experiencing challenges with rare diseases that will allow them to actually be able to step forth. We also saw some amazing, tools that are also available to patients and families themselves. And the OrphanNet has something that we saw at the World Orphan Drug Congress in Barcelona last year. Again, with some cautions, obviously. I know in Brazil, Casos dos Raros, using some very advanced, again, technology to be able to better identify and to better characterize rare disease patients. So this is just the beginning. I think it will be an amazing advancement in terms of being available. And again, available, in a lot of environments, though it will be important to see, how affordable it is across many environments. This is what I wanted to move to quite quickly, and I don't want to, I know I'm going to run out of time here. Though, is what we really talk about, though, and what the WHO resolution that we're putting forth talks about is, as we know, with the UN Declaration on Rare Diseases, one of the important things in it was to recognize that rare diseases is, of course, not just a clinical condition. It's not a medical condition. It's not just a genetic, genomic condition. It is, in fact, a multi-system condition. It's one that's also multifactorial. It affects people both in terms of clinical, but it affects people in terms of social, and affects people in terms of occupation, family capacity. It also affects people in terms of their mental health. So this is a chart that we developed in a research project we're doing through the International Research Consortium on Rare Diseases that I'm actually leading, starting with a literature search, but then really, kind of analyzing the research data to try to identify, at the end of the day, what we wanted to talk about was what's the impact of getting a diagnosis or getting access to treatment on patients or not. And creating from the research that we've done a bit of a visual to look at, how is it that, what is it that kind of creates the kind of impacts, and recognizing that, we've got health system, inputs. So this is what we're looking at here, that they have an impact in terms of what patients and families receive by way of services. And this then has an impact in terms of what that lived experience is. So the literature we've looked at, we've now organized to identify the fact that there are probably three key domains that we can look at in terms of the how the health system, works, what the patients receive, and then what happens at the end. And I won't go into deep detail here, but it is a paper that we're hopefully going to finish up in the next a month or so and be able to put out there for really some review, recognizing that awareness, access to healthcare professionals who can recognize the disease and also get referred to specialists on that left-hand column, and then getting access to the right kind of therapy and ongoing monitoring has obviously a real influence in terms of how well the patients are doing clinically, how well they're doing in terms of being able to uh, um, get access to the right kinds of support, and then also then that has a huge impact in terms of what their clinical outcomes are. But as importantly, as we say, well, rare diseases as well as any disease is not just a clinical manifestation, but it also has a huge impact in terms of people's social lives. And that means that the care coordination integration, especially for rare diseases, which are oftentimes multisystemic and requiring, integration of many different types of care, the ability to get that care in the community, also have the right kinds of social and financial support. This has, real impact in how well people are able to continue in their lives in terms of their family relationships, going to school, being able to get access to the right kinds of, maybe training, disability support in order for them to function in real world settings and to be able to not only care for themselves, but their families, to become, meaningful members of society, which is kind of what we're looking at in terms of what the overall most desirable outcome is. And then recognize it that in many cases, as with all diseases, rare diseases has a huge impact in terms of people's mental health and well-being. And this is probably the area where we do the least in terms of good, dedicated kinds of resources. So just recognizing that this is just a different graphic around the same thing that shows, again, that these are interrelated. I don't want to overdo it. However, and this kind of goes back to my theme of talking about can we ever get to equity, is that is economics the primary determinant of whether or not health outcomes accrue to a country, to a society, community, but also in individuals. And I think this is something that is really not to be under, I think, recognized. And it does cost a lot to live with a disease, and increasingly costs even more now as we're talking about the opportunities to live with a rare disease or a disease in which there's a great deal of opportunities from the point of view of technology. So, and of course, requiring in many cases a huge investment in terms of public health. And this just kind of is a visual diagram of all the different kinds of factors from the research that suggests the determinants in terms of healthcare access. At the end of the day, what we do know, of course, is that health systems and the economic factors play the biggest role for about 50% of it. There's a lot else involved, including culture, including policy, including the awareness and advocacy, and the level of science and technology of that society. So a lot of it is beyond the economics, but certainly a great deal of health system and economics still drive, the ability for people to get access to, the best health care. This is just a quick slide to look at how funding for healthcare kind of goes along with the gross national income index, but not entirely. In some respects, though, what we see is health-related outcomes are not necessarily tied to how much money you're spending in healthcare expenditures. I think the U.S. is a very good example of that. Switzerland is a good example of that. The only outlier I see in here, which is kind of interesting, is Singapore. This is just a quick slide to kind of talk about clinical trials, and I've used it in other kinds of environments, really from the point of view of encouraging more engagement clinical trials in areas that are not just North America, not just, Eastern Northern Europe, and the need to actually increase the diversification of clinical trials, in part because we need the diversification, but also in terms of, making, well-rounded clinical trials, but also because investment in clinical trials is so important for a country, so important for a region, in order for it to have increasingly investments in terms of monies, in terms of new technologies. It also provides an opportunity for healthcare professionals and patients to get access to this new technology. I'm going to talk about this a little bit later, but it goes along with the whole issue around inequities and disparities. This is just a brief slide to look at newborn screening, which is, of course, a key component in terms of diagnosis for rare diseases. And it only shows that in many cases, of course, your higher income countries tend to have more investment in newborn screening. But to me, there's some really interesting kind of not so much expected. If you look at it, Italy has the most investment in terms of newborn testing, the United States second that, but you look at countries like Turkey, Poland, Costa Rica, Chile. Philippines is a huge investment in terms of newborn screening. So this is actually quite interesting, and much more so than many of the much more developed countries. For instance, France, you might have thought would be a huge investment, especially with their rare diseases, but in fact, they're not a big investment in terms of newborn screening, which is probably one of the easiest routes to diagnosing rare diseases easiest routes to prevention in terms of rare diseases, but very uneven across the globe in terms of the investment in newborn screening, the number of conditions that are identified, and then the follow-up in terms of those conditions. I want to belabor this, but again, bring it back to the fact that, of course, rare disease is a global phenomenon, and we recognize this early on with Rare Disease International push to have when the first political declaration of universal health coverage was being passed in by the United Nations, push to have rare diseases identified as a unique disadvantaged group, feeling that, if we did not have it, so that in fact, even if universal health coverage was coming in, rare diseases were going to be left out. We're able to not only successfully do that, but had it repeated in the 2023 renewal of that UN declaration. But beyond that, then we have the UN resolution on rare diseases, which we also had passed in 2021, pushing us toward this year, which we're hoping to have passed a WHO resolution on rare diseases, which is actually much more important than the UN, because the WHO resolution really calls upon member states, countries, to engage in activities and to be accountable for the activities. The four big pillars we talk about here is set objectives, have accountability for what it is that they're hoping provide, they're setting out to do, committing to do, report on those achievements, have a budget that's dedicated to rare diseases, and then have guidelines and principles that would actually inform how not only monies would be spent, but also the implementation of different initiatives, including implementation around empowering people living with rare diseases to participate. So this is something that is right now just passed the executive committee of the WHO. Hopefully in May, we would see a resolution on rare diseases, even in these very challenging times. This is just to identify the different aspects of rare diseases that are included in there. I just wanted to put this up very quickly because it helps me segue to what I want to focus on very, very quickly and in the next 5 minutes or so, and that is the challenges in terms of the investments in rare diseases globally. One of the areas I think, as mentioned earlier, that I'm very much involved in is Asia Pacific. And again, 60% of the people living with rare diseases are in that Asia Pacific area. And yet, if obviously they don't have 60% of the investment, 60% of the resources. I'm not going to go through this in detail, but I really want to leave it with you to really know that across Asia Pacific, to me, it's a lovely microcosm in terms of what the world is like, because you have some of the wealthiest, most well-advanced countries in rare diseases in this area, but you also have some of the most challenged, and you also have very uneven investment in rare diseases. So just because a country is doing something in one aspect of rare disease does not mean they're doing something right across the board. One of the things we do look at, and this is the definition of rare diseases, we can see vary, which I don't get too much hung up on. The fact whether we have a single definition or not is not so important as the question of whether or not there are national plans for rare diseases. Is the company itself investing in rare diseases? Are we actually putting in the kind of resources that we can have access to treatment, that we will have specialty hospitals, and that we're creating, pathways for diagnosis and for registering patients? And again, I'm not going to go into deep detail here, but just to say that even across the Asia Pacific region, we see huge variations in terms of what the investment is and how it's being done, and in fact, the kinds of outcomes they're getting. We're hoping to push forward at the end of this year. We'll have an Asia Pacific conference in November, building on the 6-7 years that we have been holding conferences there to try to come up with a regional plan for rare diseases, to engage countries to collaborate with each other, to share resources, and also really be able to hopefully share some of the burden in terms of the work around rare diseases, but also best practices there. As you can see, we've got some countries that have done a great deal of investments in genetics and genomics, others that have done more investments around being able to provide some form of centers of excellence. But again, it varies. And I think this is what we also want to do, is encourage the facilitation development of centers of excellence across the region. And some of them that are doing a great job in doing it virtually, but also like in China, you've got key hospitals in the different regions in Beijing and Sichuan. But the outreach they have goes far beyond the hospital itself because of their use of telehealth and telemedicine to be able to do the outreach. So this is, I think, kind of what we're looking at, some of the models in terms of where this is happening. Japan has a national center, but they also have outlying hospitals. Some of the countries that are doing really well, I think, I like South Korea, for instance, has a Seoul is their national center, but they have 11 regional hubs. Again, connecting with them and being able to serve patients that are not just at the center, connected to the center hospital. So this is where we see some of the real opportunities to really be able to share some of that best practices. Same thing in terms of data, in terms of registries, how and what are the kinds of registries that different countries are putting together. Is there an opportunity to share in those practices? We're not really trying to talk about how we can share data across countries yet, but at least be able to share practices that will allow us to do a better job of collecting within each one of the countries or states themselves. For my money, to be honest with you, the country that does the best job in terms of rare diseases is Taiwan. Taiwan has always been a leader, and in part because they have a very strong Taiwan Rare Disease Foundation, which has helped to push and promote this. But also, they had very early on a Rare Disease Act. They have a real registry for rare diseases. One of the important things I find for Taiwan is they identify rare diseases, put them into a rare disease list, so they may have only a number of rare diseases. But once you are identified as a condition and you're a patient and living with that condition, you get access to all of the kinds of health and social resources that is available. So this is for me a very comprehensive, integrated kind of care that we don't see in many other places. They have reasonable good access to new orphan drugs, but they also, really do engage with the patient community, which itself also provides some of the social support and the actual training and education. So I think this is if one were to say, okay, give me an example of a country that is doing an amazing job in rare diseases, look at Taiwan. The other countries I think are a bit more challenging in terms of resources, and as you can see, Malaysia. The Philippines, I want to come back to as having one of the best rare diseases newborn screening programs. They have invested in it. They have a leading physician who's been doing it, and as they tell us clearly, they're doing newborn screening across 9,000 islands. Even during COVID, we're able to continue to do newborn screening, collect them, and be able to continue to provide genetic counseling to these patients even during that time. Malaysia, I'm going to point out as a challenge for all of us because Malaysia is one of the few countries that does not use dried blood spots. They're still using cord blood for newborn screening. And this is a real limit then in terms of how many diseases they can actually diagnose. So they only currently have two conditions that they're actually diagnosed in Malaysia, and there's a lot of work being done to try to kind of create a greater alliance around newborn screening among the geneticists there to see if, how we can actually do better job in terms of the education and awareness. And they're not the only country. There are other countries in that Asia, Southeast Asia, Eastern Asian area that are using, and are relying on um, cord blood. And this is, something that's a huge limitation in terms of the ability to advance in terms of newborn screening. This I just wanted to show a side by side. I won't go into deep detail. Again, differences across even one region with regard to newborn screening and how many conditions are covered, and not only how many conditions, what's the coverage, what's the area, how many families, what percentage, of families are you bringing in, and then what are the ways in which you're providing access to medicines. Some of the ones that are most challenging for me is Australia, which actually has a life-saving drugs program, but they only include 16 drugs, 10 conditions. They've only ever treated 430 patients. So it's a real head scratcher when you look at some of the countries in terms of how they're approaching this. Singapore to me is an absolute, and I say this to them all the time, it is absolutely unconscionable, their inability to actually fund drugs for rare disease, being a very wealthy country, very good healthcare system. But again, rare disease is actually funded out of some kind of a donations program, which means that you have very few patients that actually get access. 4 conditions, 7 approved patients. It actually is quite baffling in terms of how they're approaching it. And when you look at Taiwan instead, in terms of their ability to actually cover a large number of patients. So I just wanted to put it forth there and look at some of the real differences. Our goal is trying to come up with somewhat of a regional strategy there. And when we talk about equity, can we get to equity? When you look at some of this, you have to say, I really don't know. Are we going to be able to bring people along? I think one of the challenges is to work at where people are, improve very much based on the health systems, based on the policy, based on the culture, based on the engagement that you can have there, and to try to get everybody to do more and to do better and to share it. And this is sort of my last slide here, is just to kind of show glimpse across the regions, the difference in which we're seeing in terms of policy, government funding, diagnosis and treatment, which we say are the bedrocks in terms of, improving rare diseases. And I think with that, I'm probably right on time to say thank you very much and happy to take any questions that people may have.
Dr. Juan Rieger, thank you very much for this inspiring presentation. It was a great overview on what's happening in the rare disease field worldwide. We do have a couple of questions here, but I think if we have questions in the auditorium, if we can share the microphone with them. And while you do that, I'm gonna ask the first one. You have played a key role in strengthening patient advocacy networks worldwide, that's no doubt. So in your mind, what are the most urgent gaps that patient organizations should focus on today? And how can they effectively push for policy changes that would benefit our rare disease community?
We push all the time for having a national commitment. A lot of things are bottom up. We see that even in a country like Brazil is a good example, a country, where you can have pockets and you've got local people that are able to bring their hospitals together and do it. So I think those are important because those are demonstrations in terms of what can be done and how it can be done, especially when you've got leaders and champions, as you very well know there. And in Argentina, we see the same thing where patient groups are coming together with their clinicians. One of the most amazing ones, network of 5 clinicians, where they're able to receive patients and send them to a clinician who can support them. But those are piecemeal efforts and they're not sustainable. So the question we want to get to is how do we get to sustainable change and sustainable access? And the only way you can do that is involve governments, get national policies, and get commitments in terms of funding. It costs money to do it. One of the things we're doing a lot, and I didn't show it here, is socioeconomic studies to demonstrate, though, that the cost of not diagnosing and not treating is also huge. When 90% of your patients in an emergency room are filled with patients with undiagnosed diseases, we have to think very hard about, what if we were to invest in those? So that to me is the most important thing, is to be able to get governments to recognize that investment in rare diseases at the end of the day not only is good for patients and families, but it's good for communities and it's really good for your healthcare system. At the end of the day, it actually is good for your budget.
That's wonderful, thank you. And funny you mentioned Brazil. Someone from the audience just asked if you have more specific data on Brazil because you didn't share.
Yeah, I didn't do Latin America in this one, and only because out of pure economy for me, I'm having to do a talk in Hong Kong tomorrow for Rare Disease Day, so I was kind of using the same presentation. I do have similar data for the Latin American countries, though probably not as up to date as I would like, because as you know, the political and economic situation in Latin America is shifting so much faster than almost anywhere else in the world that it's really hard to keep up. But yeah, I do have, and I want to be able to explore that more because I think it's important also. We're sharing the information across Asia, Asia Pacific, and Southeast Asia to the countries themselves. Last year, we had a workshop in the Philippines. We had 6 countries that represented with policy leads, and we shared it, kind of, here's how you're doing, here's how other countries in your region are doing. What can we do together? What can we do better? And I think that will help us in terms of being able to improve the area. So we'd love to do more with Latin America. I think it's a very much of a moving target, but we really, recognize that some of the best things is happening in terms of rare diseases in Latin America, and some of the real challenges and what's really hurting us is we see countries that are going backwards.
Great, thank you. Another question from the audience here. Can you talk about any cultural or political features that make a country more or less likely to support rare disease research and support?
Yeah, and again, I didn't go into other countries, but I would say you have to start with where countries are, right? In some countries, of course, rare disease is a terrible stigma. And so I'll give you quick examples, and these are not, kind of non-examples. Middle East, where they're really investing big time in rare diseases right now, and they're trying to address what they call, high rates of rare diseases that are, in families. And, based on the fact they live in tribes, there's a lot of intermarriage there. They have a high degree of recessive conditions that actually do, manifest. And so they're trying to get a handle on it by actually doing genetic and genomic testing. And they're trying to help families identify if they're at risk in terms of rare disease, but they're also pouring monies in terms of treating these diseases because they recognize that this is, in fact, a huge barrier to their being able to advance their health system and being able to advance in terms of culture. But there's a stigma there. And so, as much as the government and health system says we want to help identify, we want to help you kind of be able to recognize if you may be at risk, families are saying, not us, we don't want to be identified because it's already a stigma. Number two, we'll see a little bit of pushback in saying, I don't know, we're not so sure we want to get rid of this rare disease. It kind of identifies our families. So it's a real challenge in terms of the awareness and the giving people better options and not, kind of putting, putting it as a mark of something wrong. I think this is a real challenge. So it's not as much clinical as it is social and psychological, which I think we have not done as good a job. And I'm a psychologist by training, and I realize we failed miserably in terms of really having an impact here.
Well, thank you. Another question here. So could you share your thoughts about the challenges at the intersection of AI, the need for sharing of large data sets, and protection of PHI, especially for images in pediatric patients?
Yeah, all of this, of course, is a moving field as well, right? And what we don't want to do is to get the technology ahead of patient understanding and the safeguards. On the other hand, I think we have in many places, including the US, including Canada, including many of the countries, we've got rules that are actually barriers and they're out of date. I mean, what the world needs to do is we need to come together and recognize where's AI now, what do we need in terms of large data sets, and get some global, I think, agreements around how we want to work in this space. And I think we can. The scientists that are involved in it, they already work together, and there's a strong community there. We need to bring along the social scientists, the patients, the clinicians to all kind of come together and to work collaborative there. I don't think everybody needs to, but if we can get a core together in terms of harmonization around principles and guidelines, we see some of it already. But I think we need to now really double down and say, hey, let's do this for real, because we're going to, kind of be hit with the barriers, but I think the worst thing that will happen is we will end up with things like data breaches, or we'll have misunderstandings that will put a full stop to things. So let's try to get ahead of that.
Wonderful. And we have one last question. I think we have time for that. So you mentioned the implementation of new technologies. Someone asks, how do you suggest to optimize implementation of some of these diagnostic tools in adulthood with the frontline clinician, who is typically overwhelmed and has difficulty keeping up with the latest diagnostic testing and the rapid evolution of the field?
Part of it will come from actually from, the nice thing about the world we live in is that the information is out there. I think patients are going to get excited about it. They're going to be pushing, especially some of the digital tools, right? I think we also need to provide the extra support and time to, frontline physicians, healthcare professionals, for them to get on board with it. But I think part of it is actually in terms of using it. I think, talk about Care Health, the AI technologies that help, identify patients that may be at risk. And what they've been able to do is introduce it to the frontline physicians, provide them with the tools, and then provide support so that if a patient is identified at risk, you've got somewhere to send that patient. You've got to put all the pieces in place. But yeah, we've got to make it so that there's a real willingness to, as with any other technology, start with the willing, start with the people that can get excited about it and create that momentum, but make it so it's truly accessible. I think part of it is also in terms of health systems recognizing, we're going to get more out of it if we do it, this way. My real fear, though, is the technology is moving so fast, and we as people tend to move so much more slowly that we have to figure out, how we're going to do that. And part of it is the, psychology of it all, right?
That was a great conclusion. So, Dr. Wong Higer, again, thank you very much for joining us today. Your dedication to rare disease is just remarkable. We all know that. Thank you. And to all who participated, thank you for joining us today. Let's continue working together and ensure that no rare disease patients left behind. And I would like to wish you all meaningful Rare Disease Day.